Welcome to Same Surgeon, Different Light. This is part of the Society of Thoracic Surgeons Surgical Hot Topics podcast. My name is Cherie Erkmen, and together with Sarah Pereira, we will meet cardiothoracic surgeons from across the spectrum of our rich community. We'll learn about backstories, career challenges, and what makes each cardiothoracic surgeon unique and valued. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.
Same Surgeon, Different Light is brought to you by the Society of Thoracic Surgeons Career Center, where you'll find free access to cardiothoracic surgery jobs, career development tools, and professional guidance. Visit the STS Career Center at careercenter.sts.org.
We're delighted to introduce Dr. Lisa Brown to Same Surgeon, Different Light. She has led the field of patient-centered approaches, especially to post-op pain management. She's developed instruments for reporting of outcomes that are meaningful to them. She's the chair of the Patient-Reported Outcomes Task Force, and her expertise in large data has led her to the leadership position as the chair of the workforce on database innovation. She is a member of the workforce on evidence-based surgery, and she has a certificate in implementation science from UCSF. Dr. Brown is a true innovator who gives us credibility and leadership in team science, patient-reported outcomes, evidence-based surgery, and implementation science. We're delighted to have a moment to learn a little bit more about the person behind this impressive list of accomplishments. Welcome, Dr. Brown. We're so excited to have you, and I would like to just jump into where you're from.
I'm from South Milwaukee, Wisconsin, which is a suburb of Milwaukee. And I was born and raised there and really stayed in Wisconsin until I ventured out to general surgery residency in 2005.
And do you have doctors or surgeons in your family?
There are no physicians or surgeons in my family. And of all my family members, I'm the second to obtain a college degree after my brother.
And so how did you come to the idea of even going into medicine, let alone surgery and cardiothoracic surgery?
I think it was a bit of a snowball effect. In high school, I was focused on business, and I thought I was going to go into either accounting or marketing or some sort of business-related field. But then I had a high school biology course. It was in the senior year, and I remember it was we did a little bit of human biology for the first time, and that's the first time that science really caught my interest. And I thought maybe I should go into something health related. And then when I got to the University of Wisconsin-Madison, I decided I needed to explore all the health related fields. And I explored everything from physical therapy to medicine, and tried to figure out what would be the best fit, and started volunteering in clinics at the University of Wisconsin Hospital and trying to get a feel for what that would look like. And I think that's when I decided, I should pursue one of these health-related fields, and ultimately decided on going to medical school.
So, how did you even know to do these volunteer opportunities? Did you have mentorship or people who were guiding you?
I actually didn't. I think I took it upon myself to realize that I needed to understand what I was getting into, and the best way to do that would be to kind of get into the field, as you will, and work at the hospital. And I actually worked in a surgical ICU as a nursing assistant. And that was fascinating because I watched surgical residents kind of running around. And at that point, I had no idea or concept of what it would be like to be a surgery resident. When I saw them working the very long hours, it was before the 80-hour work week. And I thought, wow, look at these people with their stamina, saving lives in our surgical ICU. And then I talked to some medical students and tried to get a feel for what medical school was like. And I actually initially was thinking, I don't know if this is for me. And I applied to PA school. And I actually didn't get in the first time around. And so they recommended getting more experience in the healthcare field, because I think a lot of the PA schools really value healthcare experience before getting into kind of it's really a short, fast track program. And at that point, I took it upon myself to go to the local community college and get my certification as a EMT basic. And so I worked as a volunteer emergency medical technician on the side as I was going through undergrad, and I really, really enjoyed that. Applied to PA school again, and the interesting thing is I got in the second time around, and as soon as I got in, it gave me pause, and I thought to myself, hold on, I think I should just go to medical school, because what happens if I get out there and, although the thought of being a PA and having a regular schedule perhaps was appealing, what if I'm in a practice where I don't always agree with the physician who's overseeing my work? And I thought perhaps I should just go to medical school and be the person who takes on that responsibility and has the practice and, has my own team. And so that was kind of an interesting turning point, making that final decision. And I think it was a hard one because I didn't have anyone close to that I knew that had done it, that I could see, that had modeled this for me. And the closest thing I had was an uncle who actually was my dad's cousin, but I call him uncle, who's a lawyer. And he was the one who said, you should go to medical school. You should do it. You can do it. And I appreciated his input and his advice and his encouragement. And that was it. Then I went to medical school.
So it's interesting that you didn't think that medical school was the right fit for you in the beginning. Why do you think that was?
I think it was, I think deep down I knew I could do it. But at the time, I was wondering how I could be a physician and also live out all these other aspects of my life that were interesting to me, such as, maintaining your relationships with your family and your friends and your hobbies and other pursuits. I had a view of medicine as being so all-encompassing and taking up all of your time and consuming a large portion of your life that I wasn't sure if that's actually what I wanted. And again, I hadn't seen anyone, have that career and balance all these other parts of their lives. So I didn't have a roadmap for that. And I thought, well, I'm going to have to figure that one out on my own. And I think that was what held me back initially, but I'm glad I changed my mind and decided to go forward with it.
So when you changed your mind, did you see that it was going to be a huge sacrifice and you were willing to give all of that up for your career? Or did you have an epiphany about how you could balance it?
Yeah, I don't think I had an epiphany about how I could balance it because I thought, well, I'm just going to dive in and see how it goes. And that's exactly what I did. And so I was a little bit older when I started. I was 24 when I started medical school. So I didn't come straight out of undergrad. I'd had some experience and time to think about life in between. And as I got going, I realized, a lot of these people in my class are just like me. They too are passionate about wanting to pursue medicine, but they have other interests. They have outside activities. They've got their relationships, family, friends, and all these other priorities. And so it wasn't, once I got into it, I didn't really think about it, too hard. And I thought, this is okay. This is doable. And my original plan was emergency medicine. So I thought, 3-year residency, was appealing. I had been an EMT, so the emergency medicine part was appealing to me. And so that was my original game plan. It was, ER was my numbers 1, 2, and 3 as I got started. And that changed quickly.
And so tell me a little bit about your friends and your family at this point in your career. You're making decisions based on your whole life experience, not just your career. So what factors went into the decision making as you started to go and lean towards surgery?
I think what it was is once I got into medical school, it was just so exciting to learn new things day in and day out, and being surrounded by all these, smart colleagues and fellow students and so forth, that I started to think about, how can I prepare myself for emergency medicine residency? And I thought about that early. So just like in undergrad and so forth, I tend to explore things pretty thoroughly before I make a decision. And I knew part of emergency medicine was trauma. And so I immediately saw that there was an opportunity to do a trauma tag along with the trauma surgeons. And so I did that in my first year. I'll never forget showing up to the hospital, Frederick Memorial Hospital, at like 7 o'clock on I think it was a weeknight. And there were 2 gunshot wound victims, and both of them went to the OR. And I spent the entire night in both of those ORs just watching the surgeons operate and repair all of the injuries. And then when those operations were over, we went back up to the emergency room later, and some of the physicians, one of the physicians was asking, what happened to those patients? What happened? How'd they do? And it was in that moment where I thought to myself, I don't want to ask, how did those patients do? As an emergency physician, I want to be the one who takes them to the operating room, fixes the injuries with my team and my own 2 hands, and then sees the patient through the post-operative period and hopefully beyond. And that really changed my thinking right there. And so I thought, I have to pursue surgery. It caught me early in medical school, and through the rest of my medical school training, the clinical rotations, I tried my hardest, learned as much as I possibly could, and I thought, if anything else catches my attention, I will pursue it and investigate it. But if not, it's going to have to be surgery, and that's what happened.
It's interesting that you say it will have to be surgery. So what was the concern at the time?
I think, I don't know if it was so much a concern, but it was more of it was other influences, other people who message you, right? And it's usually not surgeons. It's usually people in other specialties or colleagues that say things like, if you can find something that you like, that you can see yourself doing for the rest of your life in terms of specialty, you should pursue that. If not, surgery is what you need to do. And I feel like we still do that. A lot of people, I still hear these messages that are given to my mentees, students thinking about surgery. And then the other thing that was interesting is people that acquaintances and so forth would make comments about me being a woman going into surgery. And I don't think they understood the gravity of the things that they were saying. Things like, oh, you must not want to get married, or you must not want to have a family. And it was like, wait a minute, I wasn't talking about having a family or having kids. I was talking about surgery. So it's how these messages happen. I think it's very different for men and women who are thinking about pursuing a career in surgery, because you'll start to get some messages from maybe people who aren't even in medicine, who don't fully understand it, or even within medicine, there's this kind of subliminal, or maybe even subconscious, or maybe even overt messaging of, well, you better think really hard about this because there's only so much time, and it's going to take up a lot of your time. And how are you going to do everything else that you want to do in your life?
Do you think that it's appropriate for people to challenge the decision in surgery? Uh, Do you think we should do it to men and women, or do you think that this kind of rigor of questioning, do you really want to do it, that we should back off on that for our mentees?
I think it's a really good question. And the way I've thought about it in kind of recent years was a little bit differently. I think it should not be different for men and women, because I think no matter who you are going into surgery, you need to think about if this is a career you want to pursue and this is a specialty you want to pursue, and how is it going to fit into your life with your other priorities. But I think one thing that we don't message to trainees is think about the level of, I think, risk. I don't know if that's the best word, level of risk that you want to have in your life in terms of the cases that you're going to do. So I think every single specialty has its place. Every single one is important. But at the end of the day, some of the subspecialties are affiliated with higher risk than others. For example, cardiac surgery. Those are some very sick patients that you're starting with. Those are some very technically tough, rigorous operations. And then the post-op care is, you have to be, sometimes it can be minute to minute, right? You need to be really kind of on top of things. Not saying it's not the same with thoracic, but it is a little bit, I think, in a higher risk category. And it's like, do you want to take that on, or is there another specialty that might fit, what you want to pursue, as opposed to something like that, right? So those are the things that trainees don't think about. I think they go into the operations and this is really cool, this anatomy is really cool, but you really need to picture yourself, if you can, being kind of the last person standing in that case. Is like, that is your operation. Anything that goes wrong, you're responsible for. And is that the level of risk that you're willing to accept? And I think thinking about it that way, because that is the type of, I think, specialty specific stress that can have an impact then on the other parts of your life. So you have to be able to choose that specialty wisely, make sure it fits for you, and then fit it into the rest of your life, if you will.
And as you're choosing thoracic surgery and you're thinking back to the time when you did decide on thoracic surgery, what was the balance for you? What were the other things in your life that were perhaps needing to sacrifice, as we discussed earlier?
I didn't feel too much of a sacrifice. I felt like all roads for me led to general thoracic surgery. And what I mean by that is, there were a couple of times, this was actually, I think this was really interesting. When I was an intern, I was definitely trauma bound. I was going to be a trauma surgeon because my mentors in medical school were trauma surgeons. Doctors John Weigelt and Karen Brazel were the two key people who mentored me and sponsored me and really paved the way for me to go into surgery itself. And so I wanted to be like them. And then when I came to UCSF, it was, I was an intern, and my chief resident was Dr. Ming Si, and he is now a congenital heart surgeon. And he told me that I was going to be a cardiothoracic surgeon. And I laughed at him and I said, that's not going to happen. And he said, no, you are, I can just tell. And I said, okay, well, we'll see. I've got 6 more years to go here. And then it's people along the way who help you really decide what you're going to do. And you look at them and you think, wow, like, I want to be like them. And it was my second year when I worked with Dr. David Jablons, who retired now, as a UCSF thoracic surgeon, phenomenal person and surgeon. And he said, you should go into thoracic, hands down. And he was so charismatic, so brilliant, and such a good surgeon. I thought, wow, someone like this is telling me that I should do what he does. That's a huge compliment. And then I also liked foregut surgery. So I thought, I like this lung surgery, but I also really, really like foregut surgery. And we had just phenomenal foregut surgeons at UCSF at the time. And it was Dr. Guillermo Campos who said, if you want to do foregut, you can do it as a thoracic surgeon. You don't have to do the minimally invasive fellowship. And so it kind of snowballed. And then I hit this part where I hit the brakes as my mind was still very much trauma oriented. But then I got into the lab and I worked with Dr. Michael Maffei, who was just a awesome, outstanding, one of the smartest people I know, pulmonologist and critical care intensivist, who's an ARDS researcher. And I worked with him for 2 years, and he was the final person who said, listen, you don't need to be rounding in the ICU hours on end. You know, we can help take care of your patients. You work with me, you work with other intensivists for the last 2 years on all this ARDS research. He's like, you need to be in the OR. You should do thoracic surgery. And he said, I think it would be a very good fit. And so it all kind of came together at the right time. And I decided, I guess someone say kind of late, as a PGY 6, that I was definitely going to apply to thoracic surgery. And I think about sacrifices. I thought, you know what, I'll just do the 2 or 3 year fellowship. But then once I get through that, thoracic looked pretty elective. And then in terms of emergencies, there aren't a ton of emergencies if you're a non-transplant general thoracic surgeon outside of esophageal perforation. There's really not a lot. And so I thought this could be a good fit for having a good life, doing very interesting, technically challenging cases, and really helping people with regards to whether it be cancer surgery and even non-cancer surgery, quality of life surgery.
You have these influences, and Dr. Jablons is supporting you through the decision to go into thoracic surgery. I'm sure that other attendings were also interested in you, or was it simply it just happened that way? I'm trying to dig into the decision-making process at the time. And do you have to have that one magical person to guide you, or, was it many people, even outside of the specialty, who were giving you advice? How did you come to this decision?
Yeah, I think that's a good question. I think it's going to look different for some people because other people maybe arrive at decisions a little bit differently. I think the one piece of advice or one thing I would do differently that I do differently now is I try not to anchor too heavily on a decision and stay put. You have to stay light on your feet. You have to be willing to pivot. You have to be nimble. And this is what I'm learning through some leadership training is, 10 years from now, I think it's exciting to think that I don't know exactly where I'm going to be. I have some ideas of what I want to do. I have a little bit of a roadmap, but you have to keep your mind open to possibilities. And I think I was so focused on being a trauma surgeon that it really took messaging from people that I looked up to and thought very highly of to kind of push me towards thoracic surgery. But once I made that decision, it just made complete sense because I could operate in this beautiful anatomy in the chest. I could still do foregut surgery. It seemed to fit with, how I wanted my career to look, because also I wanted to be I want to be a health services researcher. So I knew I wanted that to be a priority. And I think that can be a little bit harder sometimes as maybe a cardiac surgeon, because I think you're clinically, it just seems heavier at most places. And so I thought with thoracic, perhaps I could have a better balance between my academic work and my clinical work. And this would be a really good fit for me. So I think decision-wise, maybe I needed a little more pushing than the next person, but my advice would be just to keep a very open mind about, and don't, anchor yourself in or pigeonhole yourself into one specialty because maybe that's not the right one for you.
So you mentioned your health services research, very unique, innovative, pioneering work, but not a lot of role models to 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 guide you, not like the clinical decision of going into thoracic surgery. So, how did you get started?
I got started in that lab time where I was working under Dr. Michael Maffei as a T32 scholar as a resident. And I immediately thought to myself, I need to have skills that are portable. I need to acquire skills in these 2 years. I can't simply sit in somebody else's lab and collect data. And, I don't even remember statistics. At the time, I thought I took like one statistics course in undergrad, and I thought, how am I going to do this? And so I lobbied for myself to take the master's in clinical research program through UCSF, and it was phenomenal. It was a 2-year program. It was heavy on study design, writing, statistics, and I felt like having that training was critical. At the time, not everyone was doing it. I feel like more and more people have master's degrees now, but at the time, it was actually relatively unique because I got that in 2010. And then through that training, then I identified other health services researchers. And you're right, there aren't many in cardiothoracic surgery, but there are a lot in surgery as a whole. And so that's where I kind of reached out to other folks at other institutions to get an idea of what they were doing and how their research looked and so forth. So that's how I initially got into it. I knew that I would never be a basic scientist. It just did not interest me. And for me, it was more about, working with the databases, doing the multivariable analyses, doing the analysis. Myself was also, I found that really exciting. For a long time, I had this data software and I was doing everything on my own. But eventually you have to gravitate away from that because you don't have time. But it's been especially exciting as an attending because through having an internal K award and watching what my interests, how they've shifted over time and getting additional training, I find that it's useful in our field because not many people are in that space. And so it's great when you can find an area within your own specialty with regards to academic work where there aren't many other people there. So that way you can kind of push the envelope and be a leader in that area. You don't want to be alone because it's easier if you got friends and colleagues with you. And I think we do have some, and I've definitely identified those people in thoracic surgery. And so it's been fun to work with them, but it's been great to kind of push the envelope and get qualitative training. So I published a qualitative study in Annals of Thoracic Surgery. I don't think our field is used to that. And also I have a certificate in implementation science as well. And so these are just areas that I look forward to kind of pushing our field towards more and more.
When you did research, was it mandatory for you to do research?
It was. So it was at UCSF, it was 2 years. You had to do it. And I looked at the pathways that were in place because most residency programs have certain tracks and none of them interested me. So I was a little nervous because I thought they're all very good, but they weren't in line with what I wanted to do, which is where I went to the chief of, at that time, went to the chief of general surgery, Dr. Hobart Harris, and I asked him for advice. And I said, this is what I want my research to look like. This is what I'm interested in. Can you help me find a mentor? And he was the one.
I want to interrupt you.
Oh,
So
yeah.
back up. How did you even know that you had a research interest in this field? Like, what was it that sparked your interest to not,
Yeah.
pipette and run gels?
So I had never done the pipetting and I don't want to work with mice or rats or any of these things. And I have zero interest in this. And so I actually had never done formal research, like real research. As an undergrad, I guess I worked on some projects, but I never really dug in deep. And so at UCSF, I went to, one of the ultimate academic surgeons, Dr. Harris, and I said, look, I'm going to be honest. I don't even know if I'm going to like research. So I need this 2 years. What I need to do is I need to do it in a way where give it my best shot, see if I like it, set myself up for the future because I'm not sure, right? I don't know. I'm not sure if this is exactly something I want to have incorporate as part of my career. So I said, I need to give it like I'm coming into it with a open mind, good perspective, and what should I do? And so he helped me choose Dr. Mathey because he's such a excellent mentor. And I've been NIH funded his entire career. And then they allowed me to do that the training program. And so I thought, okay, this is it. And it wasn't until then, till I was in the master's program working with Michael and his whole team. I mean, he had a cadre of researchers working under him. They were all in K's and working towards R's, and he had that quintessential lab. And it was at that time where I thought, this is really, really exciting. And so that's when I finally bought into it. It wasn't until I was doing it.
So perhaps if it weren't mandatory, would you have moved forward with just a clinical career?
It's possible. And to be honest, this is one of the few times in my early career, talking medical school, where I went a little bit against the grain of what my mentors recommended, because I had my sights set on UCSF for a lot of reasons, for the trauma experience, but also I thought to myself, they have every other subspecialty is super strong there. And if I changed my mind, I could pivot and do any of these other things and I'll learn so much. And I wanted to get to the West Coast, to be honest. But my mentors, one of them was actually pushing me very hard, not surprisingly, Dr. Weigelt, to go to UT Southwestern, because it was historically just 5 years clinical experience. Obviously the trauma history there is as well known to all. And I think I could have done just fine there. But I thought to myself, I owe it to myself to give myself an opportunity to see if I even enjoy research or enjoy this academic side of things, to see if that's which way I want to go. But at the time I was finishing med school, I could see myself going either 5 years, really good clinical training and go out and work, versus academics. And I was a little nervous going to UCSF thinking, I don't know if this academic shoe is going to fit. But it did.
So when you think about research, there are many people who've had research influences all the way from undergraduate, but then like you didn't have influences or experience until residency. Is it ever too late to open that mind? Like you said, you have to approach everything with an open mind. Is there ever a time when it's not possible?
I don't think so. I think the further along you go, I think the harder it does get, because you perhaps are, let's say, in a private practice and you are, you know, uh, making a good salary, perhaps you have, family to support and those sorts of things. And then it can be harder to transition to an academic center, but it's not impossible. I've seen people do it, later, transition from private practice to the academic setting. But I already kind of knew that that would be harder than going from academics to private. And so I thought, let me just stick in this academic track, see if it works for me. And then if it doesn't, I could always succeed in the private practice sector.
So tell me a little bit about how you were able to function in this research setting, not having done research, and you have, clinical expertise and confidence, and you know what you're doing, and now you're put into this high-powered lab with very little experience.
I actually think I worked out fine, and there wasn't a time where I felt out of place. And I think that was for two reasons. One, I like structure and I like learning. So I had the formal structure of the Master's in Clinical Research program to back me up. And as I went through those courses, I learned so much in 2 years. I even took an extra scientific writing course on top of it, which improved my writing significantly. And then it had to do with Michael Mathey, the mentor, because the PI of the lab, he was so inspiring and so optimistic. And we had, lab meeting every Monday, and he was in constant communication with us every day. The whole lab was cohesive and supportive. And I think that made all the difference. It was not competitive. I was the only surgeon in the lab. It was primarily intensivist, pulmonologist, anesthesiologist, and so forth. And so I think that sort of environment was perfect. for me to get my start and to have this, get up on the right foot in terms of research. And then I don't think I realized it at the time, but now I look back and I think, wow, like his lab was an absolute, I mean, I knew it was a powerhouse, but you realize like how much of a powerhouse it was. Like, how do you as a PI, that is pretty much 24/7. Your job is your lab. And the number of people that he's mentored has been, it's just astounding. And even after me, more surgical residents than he had a pipeline of general surgery residents who went into his lab.
So your research covers, I mean, your portfolio is vast. Can you describe to people who are not familiar with even this field, uh, what your research is?
Yeah, I think over time, what's happened is it has really morphed into the end goal being how can we improve perioperative healthcare delivery with regards to setting expectations for patients and their families, patient education, and basically improved quality of life metrics after surgery. And that's really my focus. I think one thing that we do really good at, especially with the STS, is we are phenomenal at measuring these objective outcomes of 30-day morbidity and mortality. And if a patient gets through the operation just fine, we don't have any of these objective outcomes that we measure by our STS database, and they have long-term survival, we count that as a win. But what we don't measure is we don't know if we left that person with chronic pain. We don't know if we left them with chronic dyspnea, and how we've changed the quality of their life that they live day to day after the operation. And so I think there's a huge disconnect. There's a big gap in how we view ourselves as surgeons and the quality of the work that we do, and maybe perhaps what the patients perceive. And the patients aren't always going to volunteer this information because they feel gratitude towards us as their surgeon for taking out that lung cancer or replacing that aortic valve. So they may not be as forthcoming about saying, something, I still have pain here and things like that. I have a lot of patients that my own practice and other people's practices that have told these quality of life stories to a third-party interviewer, but had never told their surgeon. And so that's one facet. But the other facet is, think about, in 2025 now, we look at, I do a lot of video visits. We have a lot of telehealth. We see patients very briefly before surgery. We don't have a lot of time to talk to them and tell them everything to expect. Lobectomy, I don't know, 40% of our lobectomy patients are going home post-op day 1 now, so they don't have a lot of time to spend in the hospital for us and the nursing team to educate them on pain management, and then they go home. And we're, on the hopefully tail end or still in the midst of an opioid crisis, and patients are really, concerned about, I don't want to be hooked on opioids. I don't really know what they are, but I'm going to stay away from that. So they're not really managing their pain. And there's all these things going on that we aren't really in touch with, because we're not as in tune with our patients because we don't see them as frequently. And sometimes they don't even know what to ask or when to call. So I think there's a very huge need right now for us to take some of that learning and put it into the, digital health sector, with support obviously from us, and see how we can improve perioperative healthcare delivery so that patients know what to expect, and then how they can be a true partner in their recovery.
So, you're talking about patient input, not only a patient-reported outcome, but even before surgery. Is the surgeon the best person to direct this assessment with patients?
I'd say yes and no. I'd say yes for the simple fact that a lot of times patients feel like they need to hear it from the surgeon. And so I think there's an expectation even there about who's delivering the information or who's providing the education, because we have a phenomenal team. And we have an outpatient nurse navigator, we have advanced practice providers, and they have done this a very long time, and I trust what they tell my patients. But sometimes even then the patient just isn't listening to them or isn't listening to the bedside nurse. They want to hear it from us. And so I think, some messaging around that is important. But no, I don't think it has to be us. And I think there are a lot of opportunities for us to develop better resources, perhaps, digital resources, maybe even get into some AI, but AI that we would control with regards to teaching patients, how to manage their pain, how to manage their symptoms, and basically what to expect. And something that's happened recently, it literally just came up last week. I thought to myself, I had a lot of patients asking me questions about when I go home, and they're still in the hospital. And it's like, how many practices really do a good job of giving all that discharge information the night before surgery? Like, just give it in the preoperative setting so the patient can read about it before they've even had the surgery, before they're even on pain medication, so they can process it, think ahead, rather than, give these discharge summaries or information as they're like walking out the door. So I think that we could do a lot to bring down the anxiety level and, worry around surgery by providing education, more in a more timely fashion, and also in a way that patients understand.
So you're fortunate. You put in all of this effort to your team, and training and infrastructure. Is there a way that you can package it for everybody else so that we don't have to do the work that you already put in? Is there some way that you can disseminate your research and what you know are best practices, to help us and to give us a little bit of a crash course so we don't have to do the master's degree, the extra certification and implementation, and teach every single one of our members of the team?
Well, I'm glad you asked that, because we just received our summary statement from an AHRQ grant on this very topic, which is basically implementation science approach to perioperative healthcare delivery, with a focus on education for not just the patient, but their primary caregiver, who's that one person who's showing up at all the visits, and making sure that they take notes, because they're going to be the person caregiving, and trying to figure out what their expectations are and how we can provide them more information. So we got a very good score. It's like so close to fundable, but I don't know if it's going to get funded. I think we're just at the threshold. And so we decided to, switch gears. We're going to update it. We're going to add some more innovative components, and we're going to repurpose it for a different institute, because we just have to keep going. And this is what we want to do. This is what we want to build. It's the patient education side, the patient-facing side of, education. Now, we've already done the interviews from patients and caregivers from 6 different sites. And what do they want to know before surgery? How do they want it delivered to them? Would they be willing to use a website? Those sorts of things. So we're analyzing that data. And what we want to do is create kind of a catch-all, basic education platform for them. And then eventually, hopefully, merge that into our efforts towards the STS database, patient-reported outcomes platform. Because at the end of the day, when it comes down to implementation science, if there's one guiding light of implementation science, it is you have to get all stakeholder input from the ground level before you build anything. And because you want to get input, you want to make it appropriate for all the stakeholders, and you need to get buy-in and support. So I could build a platform right now, what I think patients need to know for general thoracic surgery before surgery, but that's not the way to do it. We have to get the patient input. You have to get the primary caregiver input. We have to get nursing, pharmacy, other surgeons, and really, really get everyone's head in the game so that we end up with a product that we think is viable and useful and works for the patient ultimately. And so that's kind of one my big aim right there is how do we do a better job of educating these patients?
So you have a lot of different patients, and each one has his or her own needs. It's so variable. And you mentioned the STS database. How can you implement this variability of patient experience to the STS database?
Yeah, so that's where the implementation science approach comes in, because at the ground level, we have to take into consideration a lot of factors, right? We need to take into account patients, especially demographics. So health literacy, education level, age, digital health literacy. And so all these need to come into play. So it's not going to be a kind of one size fits all approach. It's going to have to be a little bit malleable, different languages. So that's what we're looking at now is as we start to build the content, we have to run it by a very heterogeneous group of people, patients, to help make sure that they understand. Because I think the problem with healthcare education materials that we've created, and I say we as the healthcare community for so many years, is we've created it. And then we just give it to the patient and, expect them to understand it. And there's actually some data to indicate that the lower the health literacy, the less likely that somebody is to ask a question, because they realize that you're putting this material in front of them, they don't understand any of it, and they're even more afraid to ask a question, than the next person. And so that you have to start at ground zero and build from there. And that's our goal.
So as complicated as the STS database is to get consensus among surgeons to measure these particular outcomes, I can only imagine that it's going to be magnitudes more complicated to get buy-in from stakeholders and a wide distribution of patients. So, um, you know, how do you do it, and what is your timeline of what's realistic for implementation?
The timeline is this is where I need to be patient, because I like things to happen quickly. And that's like the nice part about academic surgery is your quicker wins are your operations and taking care of patients, because you take out the lung cancer, it's out. But your other wins, you have to be more patient with it. Those are your academic wins. And so getting this patient-reported outcomes platform off the ground for the STS, which is what we're working on right now. We're very excited that we have approval from the STS executive leadership to put out a request for proposals to companies and vendors to, perhaps build a PRO platform for us, build upon what we already have. We already have a baseline patient-facing side of the application and a surgeon-facing side of the application, but it needs to be built upon to get into production mode. And so that's the next step. And so we're really excited about that. But I think the timeline on that's going to be several years, because even that, as we build it, we're going to have to go through site testing, and it's always an iterative process. That's another thing about implementation science is, we could work with a bunch of tech people and build the platform with the most bells and whistles we think is really exciting. But if it was expensive and then it falls flat and patients don't use it, then, we've totally missed the mark. And so that's where we have to start. Timeline wise, gosh, I would estimate that it's going to be several more years before we even get something that we can hold in our hand and, get patients to use, and not even in a clinical setting, but just as like a test setting, right? Get them, put it in their hands, see what they like about it, see what they don't like about it, do some quantitative testing and some qualitative testing. And then as that's occurring, I'd like for us to be building the educational component alongside of it as well, because as part of the PRO platform, we need to provide some incentive for patients to enter these data, answer these survey questions, right? Because if they're just going into an app and they have so many things going on around the time of surgery, of course, as they should be focused on themselves and their recovery. And here we're asking them to, why don't you log into this, STS PRO platform and answer these surveys? And it doesn't, by the way, it's not always linked to your clinical care, your surgeon may or may not use these data. Patients may think, well, why should I do this? So my view for the future is that if we had a very strong perioperative educational and informational component to that, to boost that platform, then patients would have more buy-in because they'd be getting something out of it. We have to provide them incentive and something and some information in order to get these data, as much as badly as we want these data at the STS.
Right. So the kind of the overarching terminology, even patient-reported outcomes, PRO, is not quite inclusive of everything you want to do because you want to impact decisions even before a clinical outcome. Is that right?
It's true.
Is there a better, wider term that we should learn to use?
Oh, good question. Is there a wider term? There may be, and if there is, I'm going to find it.
Okay.
Because
I didn't put you on the spot. I just
so,
wanted to make sure that I wasn't missing something. And I guess another question is I'm sure that there are many people at all different levels of experience who are interested in this. And how do they gain the training, offer help with all of the work that needs to be done?
oh, there's a lot of work. This is a heavy lift. And we've had a phenomenal STS, patient reported outcomes task force, that's been very stable over the last 3 years. This is a group of surgeons, cardiac, congenital, and general thoracic, who are highly committed and passionate about patient reported outcomes. But as I've talked to them, I also am big on not spending people's time inappropriately. I want to optimize everybody's time because time is is the most valuable asset we have. And so for the last 3 years, as we've been slowly building this platform, we actually haven't had a lot of a need for input at that point, because a lot of the input that we need is going to come much later. It's like the icing on the cake is what surveys do we need to put in front of these patients and what time intervals, and those are decisions that we still are a couple years away from making. It's right now it's about getting the digital health platform made, and that's in the hands of the computer engineers and the informatics people and like the tech people, is just putting the nuts and bolts in place so that when you click something, what you want to happen actually happens. And we have that in place. If I wanted to answer a survey, I could put in all my answers to the survey, and then I could see my score, quality of life score, compared to other people who've had a similar operation in the STS database. And so we've got it, pretty far along, but there's still a lot of work to do. But I will say this, the door is always open. Fortunately, there's a lot of interest in this, and anyone who wants to participate, I will be happy to talk to them and get them enrolled.
Great. So when we look at the arc of your career all the way up to where you are now, leading the implementation of patient experience into the STS database, it sounds pretty smooth. It sounds like everything has gone well. But that's not always the case. Are there any mistakes or regrets that you can think of, or hiccups along the way that shaped your experience?
Ooh, that's a good question. I think it's been relatively smooth, but I think the key is to keep an open mind and also to leverage kind of your relationships and your interactions with other people who have the success that you want. So I'll give you an example. When I was first starting out, I think it would have been nice to arrive at this research focus earlier, because I'm 10 years in, and I think we're really catching momentum and steam now. But now I'm outside of the range for a lot of the early career scholarships. And so a lot of these scholarships are available if you're in your first 3 years out of training. Those are most of the society ones. Now, I'm not going to complain because I got the TSF Research Award and I had an internal K. Was unable to convert that to a federal K, but that's all right. But then what you do is you kind of just keep moving. And at one point, I got the Carolyn Reed Traveling Fellowship Award, and that's typically used for people to go to another institution to learn a new skill. But I had just finished training like a couple years out. And so I thought maybe I apply this to my research. And I traveled to the University of Michigan, which has always been a powerhouse of health services research and surgery, and meet, Justin Dimmick and Amir Ghaffari and all these people who are doing this high level work and go down that road. And so I got the opportunity to travel there a couple times. And it was actually sitting with, Justin for about 30 minutes when I was focused on readmission and kind of health policy and quality and things like that at the time. And he said, do you really want to go down this road? Because in terms of NIH, you're going to be competing with like health policy experts and, economy and folks and things like that. And he said, let's think about what really motivates you and what could you build an entire career around in terms of health services research. And so I gave him some examples of some patient interactions and things, and that's kind of what sparked it. And sometimes you just need to allow yourself time to think and like get away from the clinical environment where it's just check the box, do the operation, go. You have to set time aside or travel or go see what other people are doing and get that advice. And I thought, you know what, he's right. I could build a career on healthcare delivery, preoperative education, patient-reported outcomes, and all these things. And I'm excited about it. And you have to be excited about this research. Otherwise, I'm telling you, writing a grant is something else. And so you better like it if you're gonna, and right before it goes in, my mentor, and I collected a mentor at Michigan. She's a PhD psychologist who has expertise in patient-reported outcomes and chronic pain management, and she's amazing. Her name is Anna Kratz. And she said, there's that point when you're about to submit a grant where you just as soon burn it up as submit it, because you're just so done. You're so tired of looking at it, and you're like kind of reached your limit. That means that you put your all into it, and you're kind of at this finish line of a marathon where like you're just gonna like either cross the finish line or you're gonna collapse right before it. So you hit the submit button, you get it in. You have to really, really, really like it. And so I think that was helpful, and having her as a co-PI for all these years since 2017, she stuck with me. We've been working together. She's been a qualitative mentor for me, having had Justin's advice, and then even to this day, with my latest AHRQ submission where we were so close on a resubmission, part of that grant was lacking some innovation. So I went right to Dr. Rachel Calcutt, who's an AI trauma expert here. And I said, how can I add some innovation to this? So you got to seek out these people who are doing it and have the funding, and just tap into them and ask them for advice and have them find the people who are going to read your grant and just like really read it and add all the feedback and all the red edits.
Do you ever feel like your dedication to research puts your clinical practice or even skills in jeopardy, or I guess at risk, or sacrifice?
That's a good question. I think at the end of the day, you have to decide what is the mark I'm going to leave on this field. And as much as I love operating, I don't need to operate, every day. And actually, I can't operate every day because of the resource constrained environment that I think a lot of us work in. I would, it's not going to happen. And so here, I would say I have a really good balance. And when I get to the end of my career, I think you have to always start with the end in mind. And you have to think about that with a grant. If you're writing a grant, you have to think, what would be the ideal RO1 that I want to write? And then what preliminary data do I need to get there? And then I think with your career, you need to think about what's the ultimate. And for me, it's three things. It's, can I get these patient-reported outcomes? Can I get the patient's voice and experience into the STS databases? Number two, can I improve the healthcare delivery experience, perioperative, I mean, before and after, for these patients and their caregivers at home? And 3, can I just day in and day out take best possible care of my patients that I can? And those are the 3, and not particularly in that order, but if I prioritize, the perioperative healthcare delivery and education, and then also the PROs are right up there with my clinical work, that's they're all priorities. And so I have to remind myself of that if ever I feel like, I should be doing more cases, or I should be spending more time on my research. And I've been in the OR 3 days this week. It's every week's going to look different. It's going to ebb and flow. Some weeks you're going to have more time for research. Other times you're going to have more time for clinical when your partners are out of town and it's just you. So you have to just remind yourself in those moments, I'll catch up next week on this, that, or the other thing. But those are the 3 things by the time I'm done with this career, by the time I retire, which I don't know when that'll be yet. Those are the things I want to have accomplished. I want to have, just do my best in all 3 of those areas.
So you're looking to the future. Where do you see thoracic and cardiothoracic surgery headed for the future?
I think it's an exciting time for especially general thoracic surgery, especially with all these newer therapies that are available to our patients. It is not as cut and dry as when I finished training, and we were able to just early stage patients went to the OR, and now it's like these targeted therapies, these chemotherapies, immunotherapies really coming into play into our earlier stage patients. And so I think the field is evolving quickly. I think there are a lot of people in that space, a lot of researchers, and that's great. I think technologically, cardiothoracic surgery is a field that attracts the technically, oriented person who's going to move the needle with regards to how we do the operation. I mean, robotic surgery is here to stay. That wasn't the case when I finished training. And so I'm thankful to my colleagues who are pushing those areas forward. I'm riding the wave of their work, but I'm trying to carve out this other area. And I think, in 2025, how attached we are we up to our iPhone, right? Or our smartphone. And you can do anything you want on that smartphone. But when you think about how we deliver healthcare and how disjointed it is and how clunky, even our electronic health records are for us and the information is for the patients and navigating the system, it's actually, I think it's kind of scary. And I think that's where we need to make the push, is how can we deliver healthcare better? Because I think we're still sometimes doing it in a way that doesn't fit the current era. And I also don't think I think we could do better. Like 85% of people, I think that's a statistic I saw, over 65 know how to use the internet. And then the demand is just going to get higher and higher and higher for using digital health resources to improve perioperative healthcare delivery, or even healthcare delivery as a whole, as the generations age. I mean, by the time Gen Z is 65, they're probably going to want to do everything through their phone or the next device. I don't even know what that's going to be.
Right. That's right.
So I think we have a lot of work to do in terms of catching up with the digital, sector. I think that's the way we need to go.
Well, I thank you so much for your time. It's really valuable to hear somebody who's been so innovative in the field of research and to bring it to thoracic surgery, a totally different perspective. We're so fortunate to have you not only speak with us today, but in the position to influence that within the STS and the entire profession. So I thank you for that. I thank you for the time. And any last words for us or trainees for the future?
Yeah, thank you for taking the time. This is really it's great opportunity to share some thoughts and hopefully help the next generation. I think just as you go through your career, keep an open mind about what surgical subspecialty you're interested in, which direction your career could go. You might find something that you didn't know you liked, so it's worth trying, and just reach out too. I think there's so many of us that are here, and we can tell you what we've been through, and we can support you, and whatever decisions you make for your career.
Thank you, Dr. Brown.
Thanks.
This has been Same Surgeon, Different Light, a podcast brought to you by the Society of Thoracic Surgeons. Thank you for listening. If you like this podcast, please rate it 5 stars and let your friends, trainees, and colleagues know about it. On social media, you can use the hashtag #TheFaceOfCT And for more information about the Society of Thoracic Surgeons, you can go online at sts.org.